Well, morning, everybody. Welcome. And it's good to see everyone, and thank you guys for having me. So happy to talk about NETs all day and try to see if we can get everybody's questions answered. We have probably just as many questions as you guys do, though. So there's where we're at. So what do we know now and what do we not know? Well, there's a lot of each. It keeps the first statement keeps changing, and that's a good thing. So we're learning more, but there's still a lot of things that we want to know. So what are NETs? I feel like this is a tough question to answer. I kind of have a general spiel. Neuroendocrine tumors, there's a number of different types. So it's a heterogeneous group. There's many different types of neuroendocrine tumors. And they are a type of malignancy. And I always say that because I think it's very confusing as a patient. When patients usually show up in my office, it's a cancer, but it's not really a cancer. Oh, it's the good type of cancer, though, which is insane to say. That's usually what folks have been told. And so it's a little bit confusing. But they originate from neural crest cells in the neurohormonal system, and I'll usually tell patients they can kind of come from everywhere between your nose and your rectum and everywhere in between. The neuroendocrine system in different locations in the body, we don't always know what it does in those organs, but it serves different functions in different areas. So the site of origin can make a difference on how these behave. First thing we start with is trying to figure out where it came from. It's not always critical, but it's usually informative about the behavior of the tumor and the other things that it can do. The functional status, you'll hear us talk a lot about functional, and when we're really talking about that, it's does this tumor make any hormones? Does it make any chemicals that travel throughout the body and cause different effects? That puts in a framework in my mind of how we want to treat things in the long run. And then we want to figure out the grading. This is the big piece. There's low grade, there's intermediate grade, and there's high grade. And I think this is another confusing thing in the mind of patients, because when you hear about cancers, most of the time you're thinking in terms of stage, right? Everybody hears stage 1, 2, 3, 4. I think that's the most commonly known thing for a patient. And stage doesn't matter as much to us here. We're really interested in the grading. We're really interested in the biologic behavior of the particular tumor, because some neuroendocrine tumors behave in a way that we need to treat very aggressively, and some can be stage 4, and we can just watch for a long period of time. So we're really interested in the grading. And I use the analogy that if you think about stage and grade in cancers, it's kind of like there's a train running towards the end of the tracks. Stage is where it is on the tracks, grade's how fast it's moving, okay? So that's kind of one way I think about it. There's the term carcinoid. Just quick show of hands, I'm kind of curious. Who says carcinoid and who says neuroendocrine tumor? Anybody say carcinoids all the time? Nobody here, not a single person wants to say. I'll still say it occasionally. Right, it's an old German term, means cancer-like. It's been whittled out of our vocabulary steadily here. I mean, you see it right here at the title of the educational conference, right? So this is an old term, generally referring to neuroendocrine tumors from the GI tract or the lung. You'll hear it called that all the time. Most of the people who've referred patients to folks like me and Dan, that's what these are called. So it's just know that additional term. Pancreatic neuroendocrine tumors, you'll also hear the term islet cell carcinoma, again, things that are kind of getting out of our vernacular. Typical and atypical carcinoid, trying to move away from those things, but you'll hear that in lung. And then you'll hear a bunch of other terms depending on the type of neuroendocrine tumor: pheochromocytomas, paragangliomas, medullary thyroid carcinomas, different types of adrenal tumors that can all be lumped underneath this and have kind of different terms. So it can be very confusing as a patient when you're trying to navigate all these things. Then there's poorly differentiated neuroendocrine carcinomas, and really conceptually in my mind, I think of this as a fairly different disease. We'll talk a little bit about that in the end. But it tends to behave differently. It tends to have different genetic features, and our approach, it varies dramatically. So when you hear small and large cell neuroendocrine carcinoma, that's usually what that's talking about. The incidence of neuroendocrine tumor is increasing. Some of that is because of earlier screening techniques, better imaging, identifying lesions that are We wouldn't have really known about it at an earlier stage, so there is a little bit of just the technologies there, but we think that there actually is a real increased incidence over time, that this is increasingly more common, even when controlling for that. It's a highly prevalent disease. What does this mean? That means there's a lot of people living with it. We constantly say it's very, very rare. But if you look relative, and I only treat GI cancers, if you look relative to other GI cancers of the number of people who are living with the disease, it's a little bit more prevalent than I think folks give it a label for. I keep this slide. This is an old slide from about 10 years ago that I had for teaching fellows. And the reason I keep it here is because we talked about grading and how important it is. And this is kind of classically how we've thought of grading of neuroendocrine tumors, and it's increasingly outdated in our mind. Where we take well-differentiated neuroendocrine tumors, we use things like a Ki-67. I think some other folks are going to talk about these things. We look at, under a microscope, we're trying to figure out how active are their cells and growing, how malignant do they look, what's their biological behavior, and we try to put things on a spectrum of grade 1, grade 2, and grade 3. And as we've learned more and more, we look at the grade 3 group, and not all grade 3 neuroendocrine cancers behave in a really mean way. Some can be in between. That's led to the evolution of a category called well-differentiated G3. And how we treat those is an area that's still under debate, it's under active investigation, because the behavior can be very different. So the whole point I'm getting at is that behavior of neuroendocrine tumors can fall on a very, very large spectrum, and there's a lot of in between. So this is very much not a one-size-fits-all disease. Imaging, I think this is something that everybody here is familiar with. It's still really how we monitor disease, okay? It's still the most critical piece. We'll talk a little bit about labs. But to many of us, the workhorse of this, if you will, is cross-sectional imaging. So when we're imaging nets, whether they're in the lung, the liver, whether they're in and around the intestines, the cross-sectional imaging is the standard. And when I say cross-sectional imaging, it means we're taking little slices right through your abdomen, for instance, and we're looking at them on a screen, and we do that with CTs or MRIs usually. CT scans, it's important how you do them. You got to know what you're looking for. You got to order it in the right way. You have to have a radiologist that knows how to give that contrast, because neuroendocrine tumors, they image a little bit differently from a lot of types of cancers. And so if you're not really doing them in the right way, you may miss things. There's probably a lot of folks, I won't do shows of hands again, I promise, who actually had imaging prior to their diagnosis, maybe a CT scan in the emergency room, and their neuroendocrine tumor was not detected. And that's not uncommon. Those ER docs, they shouldn't be looking for neuroendocrine tumors. That's not on their radar. But if it's done in a certain way, you may not see things. But done right, CT is pretty much our staple of imaging. It's cheaper, a little bit easier to do. It's less time consuming, and is still kind of our staple of how we monitor neuroendocrine tumors. MRI, in my mind, there's advantages to both. MRI tends to be a little bit better at looking at the liver. CT tends to be a little bit better at looking at some other structures. Really, at the end of the day, you're going to see some stylistic differences between everywhere that you go. A lot of that has to do with the radiologist there, what we feel comfortable with. I trained at a CT institution. I moved to an MRI institution. And so I adjusted to my radiologist accordingly. A little bit more expensive, a little bit more time consuming. You have to spend a lot of time in a narrow tube. You can try to do open MRIs and everything else, but those are kind of the things that you guys have to come across on it. And we like to kind of also, again, make sure that those are being done in the correct way to image for neuroendocrine tumors. So fancy new and old things that I'm sure everybody here is aware of. Really what we're talking about is somatostatin receptor-based imaging. So it's leveraging that neuroendocrine tumors are covered with little receptors often that can grab hold of chemicals and light them up under different types of imaging techniques. Octria scans, anybody here gotten an Octria scan in the last year? Okay. Still done in some places, and there are some locations where they may not have a PET scanner within 6 hours, but they still have a SPECT scanner at the hospital, where we'll still see some Octria scans done. It's been largely replaced by PET scanning, and if you look at it in clinical trials, it's an inferior technology. I think we have to say that. There are some roles for using it, but at the same time, it's been largely replaced. So probably a lot of folks are not getting that, but these were commonly done as little as 10 years ago. In both of these cases, what you're doing with these nuclear medicine techniques is giving a little kind of radioactive tracer, lightly radioactive. I don't want you to think that you're getting Chernobyl injected into your veins when you get this, okay? And that goes and hovers and sticks on a tumor, and it'll light it up so that a camera can pick it up. And in PET scan technology, it's a much different way of acquiring those images and restructuring them. And you can fuse them with those CT scans and even the MRI scans to try to get some accurate pictures. Gallium dotatate PET imaging, as well as copper-64 dotatate PET imaging. These are things NetSpot and DetectNet. Which one's better? Well, I'm going to leave that to a debate. Yep. I was going to say, yeah, I was going to leave that to Beth back there because you don't want me talking about it. What's the best? Really, stylistically, people are going to use different things. So as a patient, I really don't want you obsessing with these types of differences. If you're at an institution, things are structured in a way for people to run things optimally. So I will tell you that I don't think that there's necessarily a better PET tracer between it, but I'm not going to detract from that conversation coming forward. Each imaging modality has its role. You don't need a PET scan every time you get scanned. They're very expensive. Sometimes they're misleading. Sometimes, frankly, the things that we see on a PET may drive us to make a decision that we don't necessarily need to make. And a lot of us are familiar with making changes in treatment decisions based on CT and MRI. But main thing is wherever you're getting your imaging, as long as it's consistent and people have a good feel of how they're doing it, I think there's different approaches. They're stylistic, and they may not be substantial. So labs, how many folks here? I said I wasn't going to do show of hands, but I'm doing it again. So how many folks here love looking at their labs on portals? No, nobody? I was going to say, I feel like everybody. I do. I love looking at labs, right? You may be surprised how little we do, okay? You may be surprised of how little attention we pay to it, okay? I'm not saying we don't. We do use labs. We do check them. We're looking for trends over time, but oftentimes our decisions are not hanging on lab work all the time. And furthermore, when you get just a CBC, there's about 80 things that are reported out to you that may be high or low. I've got my screen silent, so I don't even see those. I don't need to see those things. So labs, you're going to get a lot of information back that can be noise. We do use them to follow folks who are on therapy and try to help make some decisions. I already said that imaging is still really our way to figure out how a neuroendocrine tumor is doing. Chromogranin A levels. Chromogranin A levels, there's a lot of kind of back and forth on chromogranins. It's kind of been demoted in our world on its level of evidence for how useful it is. It's suffered from the fact that many different labs do this a different way. So frankly, if you're a patient and you walk into LabCorp, you may go down the street to Quest and your chromogranin's quadrupled. Hadn't really changed. You got it drawn the same day. They're just assaying it a different way. So this can be very confusing for chromogranins and has probably hurt its utility, in addition to the fact that many different things can make chromogranin levels go up that have nothing to do with neuroendocrine tumors. Medications can make changes to it. Dietary changes can make changes to this. But this is one thing that most of us still follow all the time, and we're looking for trends over time. It's relatively cheap and it's relatively easy to do. 5-HIAA levels for those that have carcinoid syndrome or serotonin-producing tumor. This is a breakdown product of that, and we use that to follow kind of levels of hormone production over time. I still like my 24-hour urines. It's just kind of the number that I'm familiar with as far as knowing when somebody's having hormone production that I can objectively follow and need to make changes on. You can do these through plasma. It is sufficient in many ways, but it's not necessarily something that always translates well in my mind. I do that because it's a lot more convenient than collecting 24 hours of urine, which is not a convenient thing. But there's different ways to measure that. That's one that you'll see often done. I'm not going to talk a lot about functioning pancreatic neuroendocrine tumor markers. There are many. There's gastrin, there's glucagon, there's measuring different insulin levels. There's things like substance P and bradykinin. There are tumors that can make somatostatin, one of the big types of treatments that we use. But really, laboratory following of that is pretty esoteric. So it may be applicable to very rare types of pancreatic neuroendocrine tumors, but generally we're not checking those a lot. Multi-analyte PCR test, most of y'all will know this through the NET test. It is a very interesting test if you ask me. A lot of us have not really adopted it in our decision-making tools. But it is something where it's trying to take a conglomerate, basically, of some things that neuroendocrine tumors can produce and try to get an accurate measurement of whether a tumor is getting worse, getting better, is likely to recur after a surgery. So I think it's very interesting scientifically. Just know that it's out there, and some folks use it regularly. So what don't we know? Lots. Labs are useful, but they're imperfect assessments. In other words, we don't make decisions based on labs alone, almost ever. They are useful for us getting a complete picture, but they are not the only thing that we attend to. At their very worst, they can be misleading. An elevated chromogranin level post-resection. You just had your tumor removed. There's no evidence of it, and a chromogranin A level is mildly elevated. Well, that could be what you ate for dinner last night. It could be the omeprazole that you're taking, the Prilosec that you got at the drugstore. So at worst, they can be misleading. There's no lab screening test, so there's no just one size fits all. Here's a lab test that's going to tell you what's going on with the tumor for neuroendocrine tumors. We want that. We'd love to have that. It's an area of active research, but just know that there's nothing that's perfect. There are scientifically promising new techniques that merit further study. I mentioned the NET test. Better biomarkers would be highly helpful for us as clinicians, but just know how we're using them. Next generation sequencing, which I'm not going to spend too much time on, doesn't have as many applications in neuroendocrine tumors yet as it does in many other types of cancers. And this is basically a very kind of simplified way of taking it. You take your tumor, you spell out the genome, and try to get an idea of certain cancer genes that are flipped on. There are some applications of that. The most common labs that are used nationally are called Caris, Tempus, or Foundation Medicine. Some of you may have had your tumors sent for those. It's an evolving field in neuroendocrine tumors, but these kinds of genetics really haven't changed a lot of how we treat things just yet. They're starting to. Okay. Surgery, this is the big one. I'm not a surgeon, and I'm going to always tell you if you can get your tumor cut out, get it cut out, okay? With some certain exceptions. What do we know? Surgery, complete surgical excision is our opportunity for cure. Surgical debulking may provide survival benefits and quality of life benefits, and I'm not going to take this away from Dr. Maxwell, who's going to talk to you about all of this. Multiple series have challenged this old idea that we have, which is if you're going in for surgery, you've got to be able to clear out 90% of tumor that you see on a scan for this to be beneficial. That's not necessarily the case. Everybody's individual. Tumors are in different areas. There's risks of different surgeries. And so sometimes if we're looking at isolated areas of tumor that if we can get out, we think we can improve your quality of life and we can significantly improve your quantity of life with tumors, and it's reasonable to do. We will utilize surgical or IR-based techniques, which I'm about to get to. It can reduce symptom burden if your tumors are secreting a fair amount of hormone. So if you're getting a lot of symptoms from tumors, taking them out's a pretty good way to get rid of them. Surgical resection of the primary lobe. This is a little bit of an interesting area and based on a study that I won't get too much into. Surgical resection of the primary lobe may have a significant benefit, but it's not necessarily something we always have to do depending on the nature of your particular neuroendocrine tumor. Aggression of surgery needs to be counterbalanced against what your goals are, what we expect your neuroendocrine tumor to do, so a little bit of prediction of the biology, and what the potential risks of any surgical approach is. Surgical techniques have improved significantly So we feel a lot better going into these operations and should. Prospective data would be really useful. It'd be great to have just perfectly randomized studies of here's somebody with a stable neuroendocrine tumor, and we had half the folks that had the exact same tumor go in and get their tumors cut out, and the other half, well, they went on medical therapy, and here's who did better. That's the type of trial we really want, right? And then surgery is just really not practical. It's really not practical because you have to make individualized decisions. So it's been difficult to acquire. IR, so interventional radiologist. So if we can't go in and cut things out, particularly in the liver, we can send folks in with catheters to try to get into tumors and kind of blow them up from the inside out. And this tends to be a little bit of a lower risk profile. And neuroendocrine tumors, they tend to draw their blood supply from arteries, where an IR doc, like they're doing a heart cath, except they just take a left turn at the liver and go into tumors and inject them with different things. They can inject them with radiation. We've strayed a little bit away from that. They can inject them with chemotherapy, and they can inject them with things that basically just cut off the blood supply to tumors. So that latter one's called bland embolization. It's not that it's boring, it's just that there's no chemo or radiation in it, okay? There's chemoembolization and radioembolization, and all three modalities can produce significant response rate. So all three of these things can shrink tumors reasonably well, really over a 60% response rate, and they can improve symptoms. I mentioned the radiation. Because we have a lot of other techniques that are using radiation, and because radiation can be a little bit less controlled, this has to do with kind of how the technique's done. If you're doing it very selectively, it actually can be controlled reasonably well. We've tended to move away a lot of that stylistically. There are some people who still do it. I'm not saying it's necessarily completely wrong, but we're always worried about the long-term toxicities of radiation and cumulative effects of radiation. So you tend to see the bland and the chemoembolizations being done a little bit more, in particular bland embolizations. What we don't know. So as I was saying, we'd love to have that trial, but in somebody who's asymptomatic, when is it best to go and be aggressive and remove a lot of tumor? When is it best to sit back and play a little bit of a chess match with how a tumor is going to behave? We don't always know. We try to all rely on each other. You know, I like asking Dan what he thinks about things and vice versa. We like having tumor boards where we're all meeting and talking together, talking about what the risks are, and that way we can get an idea of what we expect out of things. We don't know if aggressive or less aggressive debulking is necessarily better. The role of grade and pathologic prediction and how a tumor is going to respond. I'm going to touch on something that I think a lot of folks ask a lot of the times. Well, if you're leaving a low-grade tumor there, is it just going to flip a switch and start misbehaving? Well, grade migration can happen. It's very rare. We don't really operate under the idea. And then the other idea, if we're just leaving a tumor there, are there pieces of it just flipping off and going to other places? Well, by the fact that there's a metastasis, there's circulating tumor cells there. So we don't necessarily know if an aggressive surgical approach is going to be able to remove the appearance of additional tumors down the line. What's the best embolization techniques? Whatever that IR doc is the best at, frankly. But at the same time, we've moved away from the radioactive techniques a little bit in our world. And how does that tie in with PRRT? What's the best sequence of using embolizations and lympho-directed therapy versus some of the newer medical tools? We don't necessarily know that either. So first thing I'd always say when we're talking about medical therapy is observation. If there's I will tell you it's never a popular opinion, but I'll usually tell folks, hey, I'm looking at a cancer on your scan here. I just watch. Let's see what this does. I'm not doing it because I'm lazy. I promise. I mean, maybe I am, but it's because we're trying to get an idea of the biologic behavior of tumors. And in some cases, there really are neuroendocrine tumors that left alone, left to their own devices, may not change for 10 to 15 years, okay? That's not always the norm. And sometimes we need to be aggressive up front, but sometimes we really think that observation is appropriate. And we can spare you the effects of some of the medical therapies that are out there. Even if we're sparing it for 5 years, can be a pretty big difference in the number of pains in the butt that you feel on a regular basis. So medical treatment landscape for advanced neuroendocrine tumors is just kind of a sum-up slide of the trials that have led to some of the drugs that we use. So we'll talk about somatostatin analogs. The most notable ones are octreotide and lanreotide. There's others in development, pasireotide. There's other oral somatostatin receptor related drugs that are also being developed. I think most folks, if you got access to Google and you type in NET, you're going to know about PRRT, the currently commercially available element in the United States called Lutathera. CAP-TIM, that's chemo. So when as an oncologist, when I'm saying chemotherapy, I'm talking about a poison that kills things that grow, all right? That's what it is at its heart, so things that are growing, it's trying to take it out. Chemo that we use for neuroendocrine tumors tends to be a little bit different than the chemos that we tend to use for other types of cancer, but CAP-TIM is a form of chemotherapy, most applicable for pancreatic neuroendocrine tumors. Sunitinib and everolimus, I'll talk about a little bit more. These are small molecule or targeted therapies. So somatostatin analogs, these are the pains in the butt that I was talking about. So these tend to be the staple medical therapy. And the role for symptom control is well established, and the role for tumor control is reasonably established as well. In other words, we think that these drugs tend to slow the growth of well-differentiated neuroendocrine tumors over time. They rarely shrink them, but they tend to slow the growth over time and control the progression of tumor. I would say if there's going to be a standard frontline medical therapy for most well-differentiated neuroendocrine tumors, not poorly differentiated, we'll get into that in a second, this would be it. A toxicity profile, pretty darn hard for us to overdose you on this, okay, even if you got stuck with 10 shots at once. Gallstones, we're a little bit worried about those in the long run. You are predisposed to having gallstones over time. There's a reason that your surgeon, if they're ever taking out neuroendocrine tumors, is probably going to take out your gallbladder. So it does increase this risk over time. They are fairly impractical. Most of the time you got to get them in office, depending on how your insurance is drugs wherever. They are a pain in the butt. Financially, they're expensive. They're not cheap. Most folks with neuroendocrine tumor diagnosis, this falls under something that insurance covers, but they're not cheap drugs. Telotrestat is a tryptophan hydroxylase inhibitor, so don't worry too much about what that means, but it's basically trying to quiet down the production of serotonin from tumors that create carcinoid syndrome. So its approval was really based on reducing bowel movements in a clinical trial. So people who have a lot of diarrhea were thinking about the use of telotrestat. We really don't have any significant evidence that this significantly alters the growth pattern. I know that's debatable in some folks' mind, that it alters the growth pattern of tumors. It can be a little bit nauseating. It can be constipating. It's really tough to take a medication 3 times a day. I think exactly 0 of my patients have succeeded in doing that, and I don't fault them. There's no way I could remember to do it, but it's supposed to be a 3 times a day medication. And it's also pretty darn expensive too, and because it's oral, sometimes it's just hard for us to get access to it. We have tough times for the world of pharmacy and outpatient oral pharmacy is a black box to me. I don't know what happens when my script goes off and whether or not people can get it and what the copay is going to be. And telotrestat can oftentimes be a tough medication to get. Everolimus or Afinitor, so this is something that inhibits a little molecule in tumors called mTOR, and it's basically kind of turning off some of the growth patterns that neuroendocrine tumors use to grow. It generally slows the growth in all primary sites, so the studies have been done with neuroendocrine tumors from the lung, the pancreas, and the GI tract that show that it slows the growth of tumor over time. On average, versus a placebo, it keeps tumors from growing for about a year versus a placebo keeping tumors from growing for about 4 months. There's a little bit more nitty-gritty to that, but it tends to freeze tumors in place. Rarely does it cause shrinkage, okay, so less than 10% of the time. There are some folks who really respond well to this, but that's not all that common. Toxicities can be irritating, can be minimal, can be life-threatening. Mouth sores tends to be a staple. So you tend to get mouth sores. We try to prevent that with some steroid mouthwashes. It can cause this lung inflammatory process that can be life-threatening. It can put you at risk for infections and some other things as well, and kind of make you feel a little bit blah. Some folks don't notice that they're feeling bad until they stop Afinitor. So this is what we call a Kaplan-Meier curve. It wouldn't be a talk from an oncologist if you didn't have these, okay? We love talking about these, and what we're really looking at when we look at these in neuroendocrine tumors is progression-free survival, and that term is basically how we're freezing tumors. What we're really interested in oncology is, can we make our patients live longer and live better? That's our goals. It's very difficult to measure how that works in neuroendocrine tumor studies, so a lot of times the surrogate that we're using is how are we controlling tumor from growing? We think that translates into better effects down the line, and so this is one of those for everolimus. Sutent, Sutent or sunitinib, it's important to know that this really only has applicability in pancreatic neuroendocrine tumors, and a lot of studies going on in other areas and some ways that you may be able to consider using it. So don't think that it's completely far-fetched that this class of drugs may have some activity in other areas, but that's being studied. Again, it's going to be very similar effects to what you see with everolimus. That Kaplan-Meier curve is going to look similar. It tends to have a lot of toxicities on bone marrow, so it can make your blood counts go low, give you hand sores, mouth sores. It can be tolerable. It can be kind of a gnarly medication to take. Cap-Tim, that's a chemo. So this was roughly 1/3 of patients had significant shrinkage. You had pancreatic neuroendocrine tumors that were well differentiated. Anytime we see shrinkage, we tend to sit up and pay attention. It's tough to shrink neuroendocrine tumors. Most of what we do in oncology is use things that are growing quickly and use that against them to shrink them. So this was a fairly impressive response rate. It may be an appropriate medication to use very early in the course of your disease. In other words, you may go see Dan back there and he says, we're going to start you on chemo right away. And that may be the right thing to do because we're worried about the symptoms you have and the bulk of tumor, and we want to start shrinking tumor for some reasons. And it may be something to put in your back pocket and frankly never use. Its role in the use for lung and GI neuroendocrine tumors is a little bit less established from evidence. There are a number of times where we will use it. It tends to cause nausea, especially the days you're taking Timidar. It tends to cause a little bit of diarrhea, and it can cause some myelosuppression, meaning your blood counts, all the things that help you clot blood and help you fight infections can go down fairly significantly with it. So those are typical chemo risks, and those things can be life-threatening. It tends to be a little bit less expensive. Again, it just depends on pharmacy. So what do we know? What do we not know? Well, we don't know what the right sequence is to play our cards. I'll usually tell folks, look, we got a lot of cards now. There's a lot more cards than I had 10 years ago, right? But we don't necessarily know the best order to play those cards. There are studies trying to look at that, so we hope to have better answers on it, but we don't necessarily know always what our best foot forward is, and we try to individualize that. We don't know which tumor is going to respond to what. So when we use the term biomarkers, we're trying to talk about something unique to your particular tumor that's going to tell us whether, hey, your tumor is going to shrink to Sutent, but it's not going to shrink to everolimus. And we really just don't have those, unfortunately. Timing and optimal integration with radiopharmaceutical therapy. I'm going to try not to talk about that too much because there's people a lot smarter than me who are going to talk about it, but we don't always know when to use these medical therapies and integrate those with that and with surgical techniques. Cabozantinib, I only mention it here because of a press release. We don't have all the data on this, but this is likely going to be another tool in the tool belt. So many of you will have seen that this released results and said that this is a positive study, and it's kind of in the class of drugs that sunitinib is with a little bit of changes, but it's going to be an option. So it's pronounced nuclear. So radiation therapy, there's different ways to do it. There's external beam radiation. Those are those big linear accelerators that are firing laser beams at tumor. NETs tend to be radiation sensitive. And external beam radiotherapy firing beams at tumors may have applicability, especially in symptomatic lesions. So I always get asked about, are protons appropriate? Almost never. There's usually not a reason we need to use those. But if you hear about things like proton therapy, it's kind of firing at specific tumors. Radiopharmaceutical therapy, drugs containing radioactive isotopes. This is PRRT. This is peptide receptor radionuclide therapy. This is taking a chemical, tying it to another chemical that's radioactive and dumping it into your veins and making sure that it sticks on neuroendocrine tumors and that radiation over time can destroy those neuroendocrine tumors. There's different types. I'm going to not touch this too much. I mentioned on Lutathera and alpha emitters. These are interesting things coming down the pipeline. I think that we're going to have more discussions on that. This has been a big change in our field. Again, I got to give you Kaplan-Meier curves, and here's another one. So if you see, this is not very subtle when we look at progression-free survival. This is a little bit of an old one. I apologize, I haven't updated it. On the NETTER-1 study, which is what led to the approval for the use of Lutathera in the United States, okay? It's important to know the overall survival endpoint wasn't met. I'm not going to talk too much about that, but this is an effective tool. What we don't know, timing, early or late. Should we use it right away? Should we use it down the road? This is a big debate. It's more of a philosophical debate than it is a scientific debate at present in my mind. I know that there's a lot of debate on that. We don't know what the optimal amount is. We're not necessarily sure what the optimal agent is, but it's good to have options. We've had a lot. High-grade neuroendocrine carcinomas. I said this is a different disease. I think about this differently. You look at the genetics of these tumors, they're different. It's almost like a different cancer. So what we do know, it's less common. It behaves differently. It's more aggressive. So these are high-grade G3 cancers. We tend to be far more reactive to these using, for lack of a better way to say it, our big guns. High doses of chemotherapy, high doses of radiation. Surgery's role is far more unclear. And frankly, it's because these tumors tend to reappear after surgery. And so we're a lot more gun-shy about using surgery. Prognosis is unfortunately worse. And because it's very rare, a lot of people don't study it. High-grade form of the disease, there's this well-differentiated G3 entity that I was talking about. That's a very interesting area of study, and it may not behave. So when you see that term G3, you may not have one that's going to behave like the true high grades. What we don't know, what's the best chemotherapy, how best to apply our new genetic techniques, and how do we treat that well-differentiated group. So I just have these up here. I'm going to run through real quick because I'm right at time in a minute. But these are kind of some of our big tools on the medical oncology side of things. This was, moving on though, that was from the a different talk. So I'll stop right there.